Welcome back to Decode Healthcare with Harshal. Man, we are hitting a massive milestone today. Part 90 of our series on the ICD-10-CM official guidelines. Today, we're entering the absolutely critical territory of Section 3, reporting additional diagnoses. Our mission for this explainer? Absolute mastery of the UHDDS secondary diagnosis rules. We're going to break down the comorbidities versus complications battle and show you exactly how this impacts severity profiling. Getting these rules right? It's literally the difference between a compliant, fully optimized claim and a massive audit failure, an error that costs health systems millions of dollars every single year. Okay, let's dive into this.
Here's our roadmap for this explainer. We'll be looking at decoding secondary diagnoses, the UHDS criteria test, chronic versus resolved conditions, the abnormal findings trap, and finally, severity and DRG impact.
All right, Section 1, decoding secondary diagnoses. Just because it's in the chart, should we code it? Think of today's session as a giant funnel. You know, we start at the top with just a mountain of patient data. You're staring at a massive patient chart, and the natural instinct is to code absolutely everything you see, right? But our job is to systematically eliminate the noise and isolate what truly matters legally and medically. We're looking for, quote, all conditions that coexist at the time of admission, that develop subsequently, or that affect the treatment received and/or the length of stay. That's the official doctrine. If it doesn't meet this specific standard, it does not go on the claim. Period.
Section 2, the UHDS criteria test. The primary filter. Let's move and see how this builds.
Into the ultimate gatekeeper for secondary diagnoses. For a coexisting condition to be reported on an inpatient record, it absolutely must affect patient care by requiring at least one of these 5 things: clinical evaluation, therapeutic treatment, diagnostic procedures, an extended length of hospital stay, or increased nursing care and monitoring. I literally cannot emphasize this enough. A documented condition cannot be coded unless it triggers at least one of these 5 criteria. If a condition is just casually mentioned in the patient's history but doesn't touch any of these 5 points during the current encounter, leave it off.
Section 3, chronic versus resolved conditions, the nuance filters. So the crucial point is, there's a stark contrast here when applying these filters. Chronic systemic diseases like hypertension, COPD, or diabetes are always reported if they're monitored or treated during the stay. Why? Because they inherently affect patient care and management. But resolved conditions never code. Past illnesses that require no active care. I mean, if a patient had pneumonia 5 years ago, it has absolutely no bearing on today's admission for a fractured femur, right? Just filter it out. It's just chart clutter.
Moving on to Section 4, the abnormal findings trap. The Section 3B exceptions.
I want to pose this high-stakes question directly to you to test your intuition. You're reading a chart. You see a lab report, and there is a glaring red number. Let's say it's an isolated high white blood cell count, or maybe a slightly low potassium level. But the provider hasn't mentioned it at all in their progress notes. Should you code that isolated abnormal lab result? What's your gut telling you?
The answer is a definitive, punchy no. You must never code incidental abnormal findings unless the provider explicitly documents their clinical significance or initiates treatment based on them. Overcoding isolated lab results without provider validation is a massive red flag, guys. It triggers severe compliance audits. Because remember, you're a coder, not a doctor. You can't diagnose hypokalemia just because the lab sheet says the potassium is 3.1. You need the provider to connect those dots for you.
And this brilliantly illustrates exactly what I mean. Look at this stark contrast. If a lab report shows a potassium level of 3.1, but there's no provider note and no potassium supplement ordered, you do not code this. It fails the test. But if the provider specifically documents hypokalemia and orders IV repletion, boom, now you have clinical significance, you have therapeutic treatment, you do code E87.6. That is the Section 3B guideline in action.
Section 5, severity and DRG impact. The bottom of the funnel.
Now, what's really interesting about this is exactly why we go through all this rigorous filtering in the first place. It's because it directly dictates hospital revenue and patient severity profiling. We split these secondary diagnoses based on the timeline of admission. A comorbidity is a pre-existing condition. It's present on admission. The patient literally walked through the doors with it. A complication, on the other hand, develops during the hospitalization, like a postoperative infection. Both are secondary diagnoses, but differentiating them is absolutely vital for tracking hospital quality metrics and figuring out exactly how sick the patient really is.
And the financial reality of this is crystal clear. You start with the base DRG for the principal diagnosis, right? That gives you your baseline weight and reimbursement. But when you compliantly apply those UHDDS rules we just talked about and stack a valid secondary code that qualifies as a CC, a comorbidity or complication, you elevate the facility's severity of illness metric. Hit an MCC, a major complication or comorbidity, and you reach the maximum risk of mortality and the maximum appropriate payout. This level of accuracy, it's the ultimate value you bring to a health system.
Which brings us to the next logical step. Mastering CCs and MCCs means you absolutely must master present on admission modifiers. We'll be covering that in Part 91 of Decode Healthcare with Harshal, diving into categories Y, N, U, W, and the high-stakes world of unregistered hospital-acquired conditions. If you found this explainer helpful, make sure to hit that like button and subscribe. Until next time, I want you to ask yourself this. If a single undocumented lab result can trigger a massive compliance audit, how much revenue is your facility bleeding right now by ignoring these strict UHDDS criteria? Trust the guidelines, guys, and I'll see you in the next one.